Hi, my name is Dan, and I'm a clinical psychiatric pharmacist, and today I'm going to be presenting on understanding substance use disorders and substances of abuse. So I had three major objectives that I wanted to cover today. First, I was going to define the diagnostic criteria for substance use disorders. Then I will be talking about a few various substances, everything from alcohol to stimulants, and I will be talking about the different types of substance-related disorders. The three major types are acute intoxication, withdrawal, and substance use disorders. Finally, I'm going to be discussing the impact of substance use disorders on pharmacists. First, I had a test your drug knowledge slide. So which of the following carries the greatest risk of fatal overdose? Cocaine, hallucinogenic mushrooms, LSD, or cannabis? So feel free to pause, think about it for a minute. And the answer is cocaine. So cocaine has cardiac effects, can cause seizures, can be fatal in overdose. Whereas hallucinogenic mushrooms and LSD in the hallucinogen class do not generally cause fatal overdoses, whereas other hallucinogenic substances can, like PCP, ketamine, so on. And then cannabis, there are very little cannabinoid receptors on the brainstem which control breathing. So in overdose of cannabis, it generally does not suppress breathing, does not cause fatal overdose. So cocaine was the answer. Next, which drug popular on the club scene and among students causes definitive brain damage in rodents and monkeys? So feel free to pause, think about it. And the answer is ecstasy. Permanent damage was seen in one example in squirrel monkeys when a certain dose was given for a certain duration. So brain damage is potentially a possibility with high dose, high duration ecstasy use. Next, I wanted to go into the diagnostic criteria for substance use disorders. But before I get into the actual diagnostic criteria, I wanted to talk about some terminology. So this slide here is called a dictionary, so just some terms related to addiction and substance use. First is substance use disorders. So this is the formal term used in the DSM-5. So in the DSM-5, which is the Diagnostics and Statistics Manual, 5th edition, this is what psychiatrists use to diagnose mental illnesses. Substance use disorder is a term that encompasses a lot. So for example, there can be mild, moderate, or severe substance use disorders, whereas the informal term addiction generally means the more severe end, but addiction is not in the DSM-5. So for example, there will be alcohol use disorders, but there's not alcohol addiction. Next is substance abuse. So this is generally considered less severe than addiction. People who abuse drugs can still have control over their life. So picture a college student who binge drinks 10 drinks in a night, blacks out, but the next day they're able to go to class, they're getting good grades, they're able to go to their part-time job and work. So they're abusing alcohol, but they're not having the addiction or substance, they're not meeting all the criteria potentially for addiction or substance use disorders. Next is physical dependence. So using substances for a long period of time causes physiologic changes in the body. People can develop tolerance and withdrawal. Tolerance is when the same dose of the drug no longer produces the same effect. So for example, someone who has anxiety is started on a benzodiazepine at a low dose, it may work for a few weeks, maybe a month or so, and then it no longer works as well. So the dose has to be increased. It works for a few weeks, maybe a month, no longer works. The dose has to be increased over and over and over until we started with a low, relatively safe dose, and now we're at a high, less safe dose. Withdrawal is when the body becomes used to having a substance on board. So when the substance is no longer there, the body reacts to that. An example is alcohol withdrawal. So alcohol is so sedating, the body gets used to it, pumps up its activating receptors and stuff. So when you suddenly stop alcohol, you can have seizures and your brain can be too active. Okay, so I hope that those terms were helpful. Let's talk about the formal DSM-5 diagnostic criteria for substance use disorders. So these 11 bullet points here show the formal diagnostic criteria. So I'll just go over a few of them. Number one, substances are often taken in larger amounts for a longer period of time than was intended. Number two, persistent desire or unsuccessful efforts to cut down on substance use. Number four, there's craving. Number five, substance uses resulting in a failure to fulfill major obligations at work, school, home, so on. 10 and 11, tolerance, withdrawal. So the point here isn't to memorize these bullet points, memorize these numbers. The point is to give you a general idea of what substance use disorder is like. So this boils down to a few things. First is impaired control. So are you trying to cut down on substances but you're not able to? Maybe you'll say something like, I'm just going to go to the bar and have one drink, or I'm only going to smoke when I drink, or things like that. But if you're not able to maintain that control and find yourself using more and more, then that could be classified as that impaired control. Next is social impairment. So people have work responsibilities, school responsibilities, family responsibilities. If the substance starts to take priority over the other things in your life, then that could be substance use disorders. Next is risky use. So are you driving when you're drunk? Are you using dirty needles to inject substances? This could be risky use. And finally is pharmacological effects like withdrawal, tolerance. Are you having those sorts of effects? That can be substance use disorders. Who is at risk? So those with psychiatric disorders are at higher risk for substance use disorders. Generally, people with psychiatric disorders don't like the way that they feel, so they might seek out certain ways to change the way that they feel with substances. So that could contribute to that risk. Next are certain demographics: young, male, single, unemployed, all at increased risk for substance use disorders. Next is trauma and genetic risks. So genetic risks are estimated to account for about 60% of the risk of developing a substance use disorder. That being said, trauma can contribute as well. So for example, there are plenty of people with at-risk genes to develop substance use disorder that don't develop substance use disorders. But if someone has at-risk genes, maybe they're abused or traumatized or sexually abused, those at-risk genes can then be expressed and cause the symptoms. So that covers the first objective. Hopefully that was helpful in defining substance use disorders, understanding a little bit of the terminology. Now let's go into some of the substances. So I just have them alphabetically. So that's the order that I'm going to go into some of the substances. This book here is called Buzzed. It's by Duke professors. It's a really good introductory book into some of this information. So I read that book as a college freshman, and it got me interested in pharmacy. It was meaningful to me. All right, let's start into alcohol. Test your drug knowledge. True or false? Alcohol before bed makes you sleep better. So feel free to pause, think about it. And the answer is false. Although alcohol is initially sedating, it alters the sleep structure. So it decreases the amount of REM sleep that people have, which is REM is important for protein synthesis, wound healing, immune function, memory consolidation, lots of things. So by decreasing the amount of REM sleep, although you might feel like you fall asleep more easily, it's less restorative sleep. So alcohol before bed does not make people sleep better. Next, is it safe to drink a glass of wine while pregnant? So feel free to think about it. And this used to be recommended, that it was okay for a pregnant person to have 1 glass of red wine with dinner, something like that. And it is no longer recommended for any amount of alcohol to be consumed while pregnant. Drug class: sedative, hypnotic. And just some interesting historical points. So breweries can be traced back 6,000 years to ancient Egypt. Distillation was invented in the Middle Ages. So this was a way to further concentrate alcohol and make spirits. And then another interesting historical point was 1920 to 1933. So 13 years was prohibition in the United States, where alcohol was illegal. One more point is that ethanol is the only type of alcohol that should be consumed. If you distill something incorrectly, you can produce methanol, which can cause blindness. All right, what is alcohol's mechanism of action on the brain. Alcohol works on GABA, which is the primary inhibitory neurotransmitter in the brain. So it increases the effects of GABA, which is inhibitory, so that's why it causes the brain to fire less, slow things down. That's why it's sedating. That's those sorts of effects. Glutamate is the flip side of GABA, and it's the primary activating neurotransmitter in the brain, and alcohol decreases the effects of glutamate. So it's doubly sedating. Increases GABA, decreases glutamate. Next, we don't really think of alcohol as a dopamine dumper, but dopamine is released and in the pleasure centers of the brain whenever alcohol levels are rising. So this often contributes to people drinking more and more because they want their levels to be rising, because that's when dopamine is released, and that's where alcohol feels the best. But there are plenty of negative and other health effects with alcohol. One is liver damage. People are more likely to develop high blood pressure, increased risk for breast cancer, and some other things I wanted to comment on in regards to the health effects is you may have heard that alcohol is beneficial for your health. So there is some evidence that supports that, but it's at very low doses. So there's a little bit of evidence that 0.5 to 1 drink per day can be helpful for certain cardiac conditions and certain circulatory disorders. But once you get to 2 drinks per day, you're increasing the overall risk of death by 51%. So it's a very narrow therapeutic window where alcohol can be helpful versus where it can be harmful. And then if you think that someone might be having issues with alcohol, there's a very short questionnaire that's commonly done at primary care offices called the Cage Questionnaire. So have you ever felt the need to cut down on your drinking? Have you ever felt annoyed by someone criticizing your drinking? Do you ever feel guilty about your drinking? Ever feel the need for an eye-opener? Drink in the early day. So if a person answers yes to any of these, it can trigger you to look deeper into their alcohol use. So within substance use disorders, it's broken down into 3 types: acute intoxication, withdrawal, and the use disorder. So we'll go through all 3. Alcohol intoxication treatment. So picture you're working in the emergency room, a patient comes in and they're under the influence, they're drunk. How do you treat them? So it starts with just a patient evaluation. They may need fluids, they may need IVs, they may need electrolytes repleted, they may need some other supportive care, but it's mostly supportive care. Depending on how the patient's presenting, you may need to get a urine drug screen or other drug screen to see if there's other substances involved. And then the unique treatment for alcohol is thiamine, and we'll talk about that a little bit on the next slide with alcohol withdrawal. So alcohol withdrawal, you're going to give thiamine as well. So thiamine is an important cofactor in like 300 plus processes in your body. And in people who drink alcohol over long periods of time, often their gastric absorption of vitamins is decreased, so they absorb thiamine less. And often people who have alcohol use disorders don't have a very healthy diet to begin with, so they might not be getting much thiamine in their diet. Why is this really important? Because low thiamine over periods of time can cause Wernicke encephalopathy, which is brain damage. The classic symptoms you'll see with Wernicke's encephalopathy are altered mental status, ataxic gait, which simply means an unstable gait, and then paralysis or weakness of the eye muscles, and you might see nystagmus. So after thiamine, the general treatment for alcohol withdrawal is benzodiazepines. So these are also GABA-A agonists. They work similarly to alcohol. They're similar to like a pill version of alcohol, but they can be more controlled. You can decrease the dose over a period of time and eventually get people off of benzodiazepines. Some are FDA approved: chlordiazepam epoxide, clorazepate, diazepam, oxazepam. And what you use is the CWA score, which is a withdrawal score to see how severe someone's symptoms of alcohol withdrawal are. There's generally 2 dosing methods. So first is symptom triggered. This is generally the preferred method, and next is fixed dosing. So a symptom triggered dosing would be something like give chlorodiazepoxide 50 milligrams every hour for a CWAS score greater than 8. And then a fixed dosing option is kind of like set it and forget it. So it would be administer chlorodiazepoxide every 50 milligrams every 6 hours for 2 days, then 25 milligrams every 6 hours for 2 days, and so on. Generally, symptom triggered is preferred because this leads to less overall benzo use and shorter duration of treatment. So that's why symptom trigger is preferred. Fixed dosing is not as preferred. The advantage is if you don't have a lot of staff, it's set it and forget it, like I said. So you can manage the fixed dosing regimen if you don't have a lot of staff to administer the CWAS frequently. Okay, next is alcohol use disorder treatment. So someone's not acutely intoxicated, you're not treating withdrawal at this point, but this is a long-term alcohol user who wants to stop using alcohol. Your options are cognitive behavioral therapy and then certain medications, naltrexone, acamprosate, disulfiram. So let's start with naltrexone. Naltrexone works as a mu opioid receptor antagonist. You may be wondering why you would use an opioid antagonist to treat alcohol use disorders. Well, certain people have a genetic makeup that when they drink alcohol, it activates their opioid system naturally in their body. So alcohol just like feels really good for these patients. So using naltrexone can block some of the pleasurable effects of alcohol and stops some of the dopamine release in the nucleus accumbens. So it doesn't make alcohol feel as good to these people, which can help them to cut back on drinking. And then if they do relapse into drinking, often their falls aren't as heavy. So they don't go back into binging and drinking a ton. Maybe they'll just had a few drinks, realize they relapsed, and start to do better. So you can prevent a relapse from becoming a heavy relapse. Adverse events are seen here, but the contraindications are recent opioid use. So if you have opioids on the mu opioid receptor, you give naltrexone, you boot those opioids off, and you cause opioid withdrawal, which just complicates everything. It's not something you want. You have to monitor LFTs. So remember, alcohol can be damaging to the liver. Naltrexone can be in rare instances too. So you want to monitor for that. And there is a long-acting injectable version that works for a month called Vivitrol. Next is acamprosate. So acamprosate works by being an NMDA antagonist that enhances GABA. And you might be thinking, doesn't alcohol itself enhance GABA and decrease the effects of glutamate or NMDA? NMDA is a type of glutamate. Yes, it does. So acamprosate can be thought of as almost like a mini version of alcohol. It may decrease cravings and alleviate negative reinforcement. The biggest side effect that I like to bring forth and talk about with acamprosate is its suicidal ideation and depression. So in the approval trials, completed suicides were 0.13% in the acamprosate group and 0.10% in the placebo group. So there potentially is a very small increased risk, but that increased risk is very severe because it's completed suicide. So it's death, the worst side effect you can get from a medication. Its dosing is easy to remember because it's 666 milligrams 3 times per day. And acamprosate can be used in patients with liver injury, whereas, as we know, alcohol causes liver injury, and we know naltrexone isn't preferred, and the next med, disulfiram, isn't preferred either. So here's disulfiram, another medication for alcohol use disorder. How does this work? This irreversibly inhibits aldehyde dehydrogenase. So when you drink alcohol or ethanol, your body breaks that down into acetaldehyde, which is a toxic component. Your body does not like that, which it then breaks that down into acetate, which then is broken down to like CO2, water excreted. So if you give disulfiram, it blocks that enzyme, aldehyde dehydrogenase. So when you drink alcohol, acetaldehyde builds up and you feel really junky. So people will get nauseous, they'll vomit, they'll have flushed skin, they'll have tremors, things like that. It feels like a really, really bad hangover. So this causes people not to drink if they know they have disulfiram in their system. It's generally used not first line. Naltrexone is first line. Camprosate's generally second line. This is used after the fact. You really have to have a motivated patient that really wants to stop drinking, or maybe someone who their family member is there to help, will administer the medications, the patient's okay with it, that sort of thing. Again, you have to monitor for liver function. A final piece or point I want to make with this slide here is with that picture I have on the slide. So different genetic backgrounds can cause some people, for example, some people have really strong alcohol dehydrogenase enzymes. Generally, it's seen more frequently in people in Korean, Chinese, and Japanese descent. They have really strong alcohol dehydrogenase. So when they drink alcohol, their body quickly converts it into acetaldehyde, and they can have negative feelings. They can get sick from alcohol. So that's actually a protective factor from developing alcohol use disorders. Whereas other people might have really strong aldehyde dehydrogenase enzymes. So they clear the acetaldehyde really quickly and might have an increased risk of developing alcohol use disorders. So genetics play, like we said on a previous slide, play a big role here. Next is caffeine. Briefly, we'll touch on caffeine. So test your drug knowledge. What common food contains caffeine? 20 milligrams per ounce. So feel free to think about it. Pause if you'd like. And the answer is chocolate, so especially dark chocolate. There are plenty of people who eat chocolate right before bed, and they're basically taking a little mini coffee right before bed with the amount of caffeine that they're getting. All right, so caffeine is a stimulant. Its history is pretty interesting. Just some little stories here. So 2737 BC, there's a story that a Chinese emperor was out with his servant. They were boiling water, and a wind gust blew leaves from a nearby plant into the cup. And the emperor drank it, and it was tea. It was from a tea plant. He was the first person to drink tea and discover the effects. Next is from 850 BC. An Ethiopian farmer noted that his goats weren't sleeping at night after eating berries from a certain plant. So they investigated the plant a little bit more, ate some of the berries, ate some of the parts of the plant, and developed coffee from that. Effects on the brain and behavior. So caffeine blocks adenosine receptors in the brain. So adenosine is a byproduct of normal cellular metabolism. So your cells are working hard all day. They release some adenosine, it binds to a receptor, and that lets your body know, okay, the cells have been working hard, we're starting to get tired. What caffeine does is when adenosine is released from the cells, it prevents it from binding to the receptor. So you're no longer getting that signal like, hey, we're tired, we've been working hard, let's slow down. Caffeine can contribute to anxiety and panic attacks. Caffeine in overdose can be fatal. This is not generally seen in adults, but it can happen. Where you'll see it the most frequently is when kids, like pediatric patients, get a hold of caffeine tablets or pills. They may take, like caffeine pills can have 200 milligrams of caffeine. They may take 5 or 10, and that's a lot of caffeine for a little human to take. Caffeine can increase heart rate, blood pressure, and then it can irritate the stomach lining. That's why some people have to go to the bathroom right after drinking coffee. Caffeine-related disorders. So like we just talked about, caffeine intoxication is a possibility, generally treated with supportive care. Caffeine withdrawal can happen. Generally, people get headaches or minor symptoms that can be treated with over-the-counter products, but you can also taper yourself off of caffeine over a period of time to prevent this. And then caffeine use disorder is not in the DSM-5. It doesn't really exist. There's not any reports that I'm familiar with of people missing work to obtain caffeine, spending a ton of money on caffeine, craving, well, I guess maybe some people crave it, but not to the degree where it's a caffeine use disorder. Okay, next is ecstasy, which is its chemically shortened name is MDMA. The drug class here is entactogens. History: first synthesized in 1912 by Merck chemists. U.S. Army began testing its use in the 50s. How does this work on the brain? Well, it's an indirect serotonergic agonist and affects the vesicle's ability to store serotonin. So it leads to a big serotonin dump. It also affects dopamine and norepinephrine, but to lesser degrees. Other health effects, ecstasy can be fatal in overdose, and then we talked about it as well on a previous slide. At high doses for high durations, it can cause permanent brain damage. Next, there is an organization called MAPS that studies traditionally considered illegal drugs for medical purposes, and ecstasy was granted breakthrough designation for PTSD patients. So they're studying the effects of giving someone ecstasy, having the person go to a therapy session, and see if that helps with their PTSD. So potentially, ecstasy could be an FDA-approved medication in the future. Okay. Ecstasy-related disorders, MDMA intoxication. There can be increased temperatures, so you want to maintain the airway. You want to cool the patient if they're presenting that way, and then you can give fluids, hypertonic saline. MDMA withdrawal, generally supportive care. MDMA use disorders, generally therapy, and also supportive care. There's really no medications for ecstasy use disorders, MDMA use disorders. That being said, is ecstasy addicting? Animal studies have shown that animals will self-administer MDMA, but to lesser degrees as compared to things like cocaine. Okay, hallucinogens is next. So this is the name of the drug class. There's many different types of hallucinogens. LSD, psilocybin, peyote, DMT, ayahuasca, PCP, ketamine, salvia, more. History depends on the agent, but LSD first synthesized in 1938, but got a bad reputation in the 50s when the CIA started to look at its effect, looking to see if they could use it for mind control. Ayahuasca, really interesting history. So 2 different plants in the Amazon, and separately they don't have any effects, but when combined they cause hallucinations. So just by chance, I guess, someone found that combination caused hallucinations. Next, effects on brain and behavior. So this depends on the type of hallucinogen taken. So the serotonin-like group causes they work at serotonin subtypes, 5-HT2A and 2C, they're agonists there. And we have antidepressants on the market that are also 5-HT2A and 2C agonists, but do not cause hallucinations. So we are unsure completely of the mechanism of why some things cause hallucinations and others don't. So that's how the serotonin-like group works. Belladonna alkaloids work on acetylcholine, and the dissociative anesthetics work on glutamate. The serotonin-like group generally isn't fatal in overdose. Generally, an overdose causes a bad trip, whereas the belladonna alkaloids and dissociative anesthetics can be fatal in overdose. Next, hallucinogen-related disorders. So intoxication, generally treated with supportive care. If someone's hallucinating, really agitated, anything like that, you can try to give benzos or antipsychotics. The degree of efficacy is mixed. You may see some, you may not. Depending on the agent, you may need to decontaminate or give antidote therapy. Hallucinogen withdrawal, generally treated with supportive care. Hallucinogen use disorders generally do not cause addiction, so they're not affecting dopamine very much. They don't activate those pleasure centers, and some people don't really like the trips or the experiences they have on hallucinogens. There's no FDA-approved treatment, and there needs to be more research in this area how to treat these. All right, next is cannabis. Test your drug knowledge. Chocolate and marijuana stimulate the same receptor in the brain. How much chocolate would you have to eat to get the same effect as one joint? So feel free to pause, think about it. This is more of a for fun question, but 25 pounds of chocolate will affect the endocannabinoid system enough to produce a similar effect as one joint. That being said, it's probably impossible to eat 25 pounds of chocolate and then absorb all of the effects from that amount. So more of just like a for fun fact. Cannabis is a cannabinoid. History, the first written documents are from very, very long ago, 28 BC from what I could find. This was used as an industrial crop for a long period of time, a cash crop. So the hemp was grown for its fiber. It's a fibrous plant. You can make clothes out of it, you can make paper out of it, so on. George Washington grew hemp probably for those reasons, to make cloth and fiber and sell the plants. This started to become popular as a drug during Prohibition. So you take away alcohol for 13 years, people started to look at other ways that they could change the way they feel, and cannabis was one of those ways. Effects on the brain and behavior is complicated. So the body has cannabinoid receptors in various areas of the brain. The hippocampus, which is needed for memory, the cerebellum and basal ganglia, which are needed for fine motor movement. So cannabis can affect those. As previously said, there are little cannabinoid receptors on the brainstem, so it doesn't affect breathing and does not cause respiratory depression and overdose. There are 85 plus cannabinoids. The most commonly known ones are THC and CBD. THC is psychoactive, CBD is non-psychoactive, but there are many more cannabinoids. Additionally, there are different receptor types. So there's cannabinoid receptor type 1, there's cannabinoid receptor type 2, there's various plants as well. So there's cannabis indica, there's cannabis sativa. Some people argue about a third type called cannabis ruderalis. So the point on how cannabis produces its effect is that it's really complicated at this point, but as it's being legalized in more places, tried in more places, understood a little bit more, we'll have a better understanding of this in the future. That being said, certain patient populations, there is harmful evidence with cannabis. So patients with bipolar disorder and schizophrenia, there is negative evidence, meaning at this point, it should not be recommended to use cannabis in people with bipolar or schizophrenia. Other health effects, it can increase the heart rate, especially if you smoke the cannabis. Burning any plant product and inhaling it can damage the lungs. There's negative hormonal effects, so it can decrease testosterone, some other hormonal changes. There's positive effects on nausea, so sometimes it's used for that reason. Positive anti-seizure effects, sometimes it's used for that reason. There are a few FDA-approved products that are either synthetic THC or CBD, things like that. Example, dronabinol, nabilone. And there's more as well. All right, cannabis-related disorders. So cannabis intoxication, maybe someone comes into the ED, they're really paranoid after using a lot of cannabis. Basically, you treat with supportive care. Maybe put them in a cool, quiet room, supportive care, and they should be okay. Cannabis withdrawal. Most are mild cases, but there are reports of sleep disturbances and anxiety. You can treat this with CBT, so cognitive behavioral therapy, and there's also a little bit of evidence for dronabinol or gabapentin. So dronabinol is a synthetic THC, it's FDA approved for certain indications, and you can think of it like what a benzo is to alcohol withdrawal. So it works the same, but you can control it a little bit more and taper off over a period of time. Cannabis use disorders, you treat generally behaviorally with some therapy, some other modes. Next is tobacco or nicotine. Okay, test your drug knowledge. If a child or animal eats a cigarette, will it cause harm? So feel free to pause, think about it. And the answer is yes, there is enough nicotine in a cigarette to make a small child very sick or even kill one. So when cigarette is normally used, most of the nicotine is blown out. But if it's consumed, maybe a little kid or an animal finds a cigarette or two and eats it all, more of that nicotine can be absorbed and can cause very serious effects. So drug class, nicotinic agonists. History, tobacco was originally used as a medicine. Then it was used as chewing tobacco primarily first, then cigars, and then cigarettes. And in the 1960s, smoking reached a peak with roughly 40% of US adults in the 60s were tobacco users. Effects on the brain and behavior. So tobacco stimulates nicotinic acetylcholine receptors, which can be helpful for certain things like memory, mental function, and it also causes a boost of dopamine to be released. So this is why tobacco use can be so addictive and so positively reinforcing. It also has other effects, so we're familiar with a lot of the effects of tobacco use: heart disease, lung disease, depending on how you use it, certain cancer types, so on. Final piece with tobacco is tobacco induces certain liver enzymes. One example is CYP1A2. So smoking cigarettes causes your liver to pump through certain drugs faster and can have drug interactions. Next, tobacco-related disorders. So nicotine intoxication, like a scenario we talked about where a kid eats a few cigarettes or something. There can be serious symptoms: nausea, vomiting, increased blood pressure, dizziness, anxiety, more sometimes. Generally treated with supportive care, but you may need further treatments depending on how severe it is. Then nicotine withdrawal, and then tobacco use disorder. First line for tobacco use disorders are varenicline, which is Chantix, combination nicotine replacement therapy, so the patch with either the gum or lozenge, or bupropion. Second line is clonidine or nortriptyline. Next, we'll go into opioids. So this is the name of the drug class, and some examples are heroin, morphine, oxycodone, fentanyl, hydrocodone, so on. History: these are from the poppy plant. Oldest records of opium use are from very, very long ago, and the first hypodermic syringe was invented around the time of the Civil War, and this was the first major wave of addiction to narcotics in America. Effects on the brain and behavior. Opioids are agonists at mu, delta, and kappa opioid receptors. The major effects are from the mu binding. Other health effects: so opioids have sexual dysfunction, chronic constipation, respiratory depression, and overdose. So they are fatal, can be fatal in overdose. So let's talk about opioid intoxication. So since 2019, Americans are more likely to die from an opioid overdose than from a car accident. So just think about that for a minute. It's really something to think about. Symptoms of an opioid emergency. So we talked about the respiratory depression. Patient may not be responding. The center part of their eye may be pinpoints. They call it pinpoint pupils. Fingernails, lips can turn blue. Slow heartbeat. What to do with a suspected overdose? Call 911 immediately. Administer naloxone if it's available, which is the antidote. Try to keep the person awake and breathing. Turn them on their side. Stay with them until emergency services arrive. So naloxone, we just alluded to it, is the antidote to opioid overdose, and it's a mu opioid receptor antagonist, whereas opioids are mu receptor agonists. So it kicks opioids off the receptors, which cause withdrawal, but also cause the person to start breathing again, which is what you really want in opioid overdose. There's different formulations, and it's not given orally due to extensive first-pass metabolism. So here are some of the formulations of it. Of the three here, currently I generally see the Narcan nasal spray the most frequently. Role of the pharmacist. So naloxone has a standing order. So for example, if you notice a patient, the standing order depends on what state you're in as well, but notice you notice a patient who's on high-dose opioids, you might recommend that they get naloxone and talk about it with the patient, see what's going on. If they're on opiates and benzos together, it would be a good idea to give the patient naloxone. Or if the patient has a history of overdose, then it would be a good patient to give naloxone to. There's free distribution events in certain states, and there's a prescription monitoring program in most states as well. So this is a program where you can go online, make sure that you're familiar with all the opioids, all the benzos that the patient is taking, make sure they're not going to various doctors or filling at various pharmacies so you can help the patient best and keep them safe. So next, with opioid-related disorders, is opioid withdrawal. The symptoms of opioid withdrawal can be seen here, and it's generally not pleasant, but it's generally not fatal. So people don't like going through opioid withdrawal, but they can and generally won't have serious long-term effects from it. As we talked about before, chronic opioid use causes chronic constipation and seems to like dry people up. So opioid withdrawal causes the opposite. People have diarrhea, they sweat, their eyes water, their nose runs, they're like leaking from everywhere. The treatment can be seen here. Some agents you'll see are clonidine, or another agent that's specifically FDA approved for this called lofexidine. And then other treatments are basically symptomatic. So you can give Benadryl for irritability, you can give loperamide for gastrointestinal issues, you can give trazodone for insomnia, and so on. But when a person's in opioid withdrawal, you can start the treatments for opioid use disorder. They have to be in withdrawal to start, but you can start buprenorphine naloxone, or sometimes, but rarely, buprenorphine alone, and then methadone. This is you determine how much withdrawal someone is going through based on another scale called the COWS scale. So similar how we use CWA with alcohol, we use the COWS with opioids. The first medication I'll be going over is buprenorphine naloxone. So its mechanism, buprenorphine is a partial mu opioid agonist. So what this means is it binds to that same receptor that things like heroin, morphine, other opioids are, but it's a partial agonist, meaning that there's a ceiling effect, there's a cap, whereas something like heroin can keep going much, much higher. So this leads to more safety, limit to respiratory depression, limit to euphoric effects, and so on. In combination with buprenorphine, naloxone is often given, and naloxone is a mu opioid antagonist. And you may be wondering why you give a partial agonist with a mu antagonist, and the reason is route of administration. So these are sublingual products, and buprenorphine is absorbed through the oral mucosa, through the mouth, and naloxone is generally not as much. It's generally considered to be not absorbed through the oral mucosa, though some studies show that it may be to a degree. So the reason the naloxone's in there, because it doesn't do much sublingually, but if someone tries to inject this product, it will be absorbed, and it will prevent people from getting high on the buprenorphine. There's some adverse events listed there, one of which is withdrawal. So even though it's a partial opioid agonist, it binds to the mu opioid receptor very strongly. So if someone's already on heroin, and heroin's in their system, and their mu receptors are activated to this degree, if you give buprenorphine, it kicks the heroin off, and now their mu opioid receptors are activated to this degree, and they can have withdrawal symptoms. Make the patient angry, make them upset with you, so wait till they're already in withdrawal before you give buprenorphine products. Monitoring can be seen there as well. Let's go to the next slide, which shows Suboxone and Zubsolv, which are common buprenorphine naloxone products. These are sublingual tablets or sublingual films. And the point to note here is that they are sublingual, meaning they are dissolved in the mouth, absorbed through the oral mucosa. So it's important to counsel the patient here not to swallow these, not to swallow the spit even. Let it sit in there for as long as they can. Because if they do swallow it, buprenorphine has a lot of first-pass metabolism, and they won't get the same dose that they'll get if they keep it under their tongue. A lot more will be absorbed if they keep it under their tongue. Okay, next slide is methadone. This is a full opioid receptor agonist. So similar to morphine, oxycodone, the other opioids, full agonist, but it's well controlled because they have to go to methadone clinics to get it, and it's long acting. So there are these risk mitigation pieces compared to uncontrolled opioid use. Another thing to note is you also wait for someone to be in withdrawal before you start methadone. The reason you do this is because if someone's not in withdrawal and still has something like heroin in their system and you add methadone, you potentially overdose them on opioids by giving them an opioid when they already had an opioid in their system. So you wait till they're in withdrawal when you know a lot of that heroin's off the receptors before you give methadone. Next is sedatives. So drug class here, sedative, hypnotic, anxiolytic, examples barbiturates and benzos. And the effects on the brain, these are GABA agonists, GABA A agonists. So they are like a pill version of alcohol to a degree. They have other health effects, so they can cause muscle incoordination. They can also cause muscle relaxation, so sometimes you use them for those reasons. And when you affect GABA for long periods of time, you're slowing the firing of the brain for long periods of time. It can impair memory and has long-term dementia risks, long-term Alzheimer's risks. So benzos are fine as a short-term agent, but I do not generally like them as long-term agents. Sedative-related disorders, so acute intoxication, basically monitor, treats with supportive care. There is a medication called flumazenil that's FDA approved for the treatment of benzo overdose, but it's associated with arrhythmias and seizures, so sometimes the risks of using it outweigh the benefits. And then benzodiazepine withdrawal and use disorders, generally sometimes switch them to a long-acting benzo, but most of the time just slowly taper them off of the benzo. Final class is stimulants. Examples are Adderall, cocaine, meth, Ritalin. How they work, their mechanism. So these block the reuptake of dopamine and norepinephrine. Other health effects, overdose can cause death. They increase blood pressure, constrict the blood vessels. Cocaine can cause seizures. Stimulant-related disorders, so stimulant intoxication, generally supportive care, cool and quiet environment. Stimulant withdrawal, generally supportive care. Stimulant use disorders, psychosocial approaches like cognitive behavioral therapy. It's a little bit of evidence for certain medications. Topiramate has some evidence. Disulfiram has some evidence in cocaine use. And bupropion has some evidence to decrease meth use. So that covers the second objective. The final piece is substance use disorders in pharmacists. So some studies estimate that 1 in 7 pharmacists develop substance use issues. 18 to 21% have misused prescription drugs, which is a huge amount. So I found some quotes from a study that looked at pharmacists with substance use disorders that I wanted to share here. So reasons for substance use. Basically, I started abusing prescription opiates that I was prescribed, and since I was a technician/intern at the pharmacy, I decided to just steal them, get my supply instead of buying them or doctor shopping. All right. Next quote. I think I just had a breakthrough. I think retail is the reason why I began abusing drugs. No, I hated my job so much that drugs were the only reason I'd go in most days. And then the next quote here is about using the employee assistance program. And this quote is saying that this person couldn't really call their employee assistant program because they felt that they were stealing hundreds of thousands of their drugs. It's not the same as asking for help if you come into work a little hungover. Next quote is, if they had a class with a bring in the junkie day, bring in the pharmacist, addict day, for someone to tell their story, 1 or 2 stories, then maybe 1 or 2 people or 3 people in that class would be like, man, I better not touch that stuff. I better not think about it. So hopefully these few slides are doing that for you rather than the bring in the junkie day or bring in a pharmacist addict day. I hope these slides were helpful for you. Next is the consequences. So the exact laws around addiction in pharmacists is vague, and this should scare you if you are a pharmacist, because you don't know, based on the situation, if you're going to get a minor punishment or if you're going to lose your license permanently. So some examples, the license can be regained. So substance use disorders are a disorder. They are an illness, just like other illnesses, deserve to be treated, deserve to have the right to practice again. But look at how difficult it can be to regain the license. 6 months minimum in group therapy, attend 90 recovery meetings in the first 90 days, assume financial responsibility, submit to random drug testing, find a recovery sponsor. It's a lot of steps. So it's sometimes a different story if you're putting the public at danger. So then sometimes these people aren't able to get their license back. So it depends on a lot of things, but the consequences can be really severe. And if you work this hard to get through pharmacy school, it should not be worth it to risk all that. So today we talked about substance use disorders. We talked about various substances and how to treat acute intoxication, withdrawal, and substance use disorders. And then we talked about the implications of substance use disorders in pharmacists. I hope the presentation was helpful. Please feel free to reach out with any questions. Thanks so much for listening.